Kapunka. That's all I know. It is a pleasure to be here. First, if I speak too fast, please just raise your hand and then I will know, slow down, because from New York, I always speak fast. Uh, you'll see on the screen there, that is our nursing school right in the heart of Manhattan. And we are at 26th and First Avenue. So we are right in the hospital corridor for the university. So this is our health sciences campus. And our main campus is a little further downtown. But it's a beautiful building. And anytime you want to come visit, you are most welcome. Okay, so today there is so much we could talk about in terms of nursing administration research that I was trying to think of how do we narrow it down. But we know I know that there are common topics for everyone. And I have been talking with Dr. Apiridi and Dr. Ornanong, and they gave me some good ideas. So I hope you will find this to be useful for your work in your current roles, but also maybe for a thesis idea. So the first thing I'm going to talk about is a technique called statistical process control. And I love this because this brings sanity to data. We are all being measured on performance, on quality of care, those types of things. You as managers have a lot of pressure. And this is a tool that is very useful and can help make sanity of the data. So what is statistical process control? So it is a technique that was developed in manufacturing, but it has been able to be translated into healthcare. And you develop control charts to monitor your clinical outcomes or your administrative processes over time. And as leaders, as nurse managers, it can help you determine if there's a change in the data that you should be concerned about, or if that is perfectly normal for your area of work. So it really helps bring sanity to all of this data that we have floating around. And it's extremely useful for monitoring nursing quality indicators, such as central line blood infections, falls, pressure injuries, all of the ones that are specifically sensitive to nursing practice and the workforce. So there are two types of analyses, and you can do this in Excel. You don't have to have a fancy statistical software, access to a statistician. You can do this in Excel. So the two types of variation in your data that it looks at is there a common cause? Is this just system noise? And so this is like everyday fluctuations, totally normal expected performances. You know, maybe there's a slight difference during a shift change, or it was a particular time of year where there's, that there's always more births, or there's more older people coming in to the hospital. And then there's special cause variation. These are your signals. This is where you might have an outlier performance that is telling you, ooh, there's something going on here. There was an issue. Maybe there was an equipment failure. Maybe there was an uptick in medication errors. So with these two types of analysis, you can understand what's your normal and where's a deviation that maybe you need to address. So why should we use it in healthcare? The great thing about it is you can get a sense, it's like a constant narrative. So you can look at the data over time, and you need as little as 4 months of data. But the more data you have, the longer you can understand what's normal performance. And you can even use data retrospectively. So as long as you've been capturing the data, you can do a retrospective analysis, and you can also do a prospective analysis. So say you do a quality intervention, you can look at the data before, and then you can look at the data afterwards. So it's a really good way to see, even if you don't have a large sample size, what's going on. Did your quality intervention work? It also helps us to avoid what we call the knee-jerk reaction, which is a slang term for basically reacting too quickly to maybe something that we didn't need to. So, for example, say you had 2 more falls this month. Oh no, what will we do? But maybe that was okay. Maybe that's within the normal expected parameters. But, sometimes, oh, there's been 2 more falls this month. And then you tell the staff, and the staff feel terrible. And what do you do? And we don't want the staff to feel terrible because we want them to support the quality and the performance. Because when staff are engaged, they feel better about how they take care of patients. They are less burned out. They feel more loyal to the organization. So when that's an important thing about statistical process control. The other thing it can do is it can identify a trend early on. So if there's a downward trend, say in a patient safety indicator, you can spot it before there's a crisis happening. So maybe it's a period of the year where, there aren't enough nurses and you start seeing safety issues happening because there aren't enough nurses. You can have that documentation and then you can go to the people above you and say, hey, we're seeing this problem with patient safety happening. We need to make sure we have more nurses. And the other thing is it's going to validate any of the improvement processes that you're doing, or it might tell you, stop investing in this improvement, this intervention. It's not helping you. Find something else that works. So for example, if you implement a new hand washing protocol, it can tell you whether it was resulting in a drop in infections and it's a permanent shift, or if it was just a lucky month. If people were like, okay, we're going to do this for a month, and then 2 months go by and maybe they don't do it as much. Does that happen to you? And then they don't do it as much 3 months later. And then you have to do re-education in month 4. No, we need to be washing our hands again. Yeah, that happens here too. Yeah, it happened when I was a nurse manager too. So these are things that happened. They are common across healthcare, no matter where you work. So, but it's really important that we spend our time looking at effective interventions and not wasting our time on things that don't work. Because you guys have enough to do as managers, right? Or future managers or whatever. But this is going to help improve your time. So I'm going to have some visual examples of an SPC control chart. But just so you know, this is what you'll be looking at on the chart. So there'll be a center line across the chart. That's the average performance, according to your data. And then there's your upper and lower control limits. So they're whatever standard deviation above and below the mean that is normal for your unit. And then your data points are plotted on this graph. And so you need a minimum of 4 months of data, no maximum. So, and here are the basic calculations for how you do this. And that you'll have a copy of the slides so you could practice. You can plug this into Excel. And the main thing is when your data points are falling between your upper and lower limits, you don't have to worry. You're good to go. It's normal for your unit. So this is really important because, some general medicine units are going to have one set of performance indicators. A general surgery unit will have different sets of performance indicators. Same with cardiology, oncology. But it'll help you understand what's normal for your unit. So that's a really important thing because we don't want to be comparing the risks by different specialty when the risks are not the same. So here's our first example. So here's a stable process chart. So hospital-acquired pressure injuries. This is a global problem. We know it's a challenge, especially for the elderly, for very frail people. And when you see this chart, you see, okay, we have 18 months worth of data. And the blue line in the middle says that there are about 3.5 pressure injuries per month. And that's about normal. And you see that, there were some months where maybe there were, a greater number of frail patients that were in there. So that's the part that's above the line. But look at that. Oh, we had a big drop down there in month 14. Well, and, normally you'd get really excited. Oh, we fixed the pressure injuries, right? But it's still within the normal parameters of the performance on your unit with your patients. So, but you as a manager, you don't have to stress out because it's still between the two red lines. That's the important part. So, chart number 2, this is an improvement signal. So this is, you've done an intervention and it showed that you've actually made an improvement. So you'll see the pre-intervention data is to the left of this green line. And you can see that the fall rates were up above, they were about 6 per 1,000 patient days. And, that was where it was hitting. And then an intervention was done, whatever the intervention was, to reduce falls. And we could see, oh, look at that. They really dropped below the lower control level. So that means the intervention actually made an improvement and made a statistically significant improvement. And so when we have a fall rate that's probably averaging somewhere around, 3.5 per 1,000 patient days instead of being nearly twice that. So that's how you can use SPC to show there was a difference made on your unit. And these things take time, but they give us the data and the tools to show, look, we actually did a good job. Now, imagine showing this to your nursing staff and being able to show, hey, look, this actually worked. And especially if they came up with the idea for how they're going to reduce falls. That's a great way to validate that, yes, what they saw and what they thought would work actually did. And same as the reverse being true, which is maybe it didn't work. But we like to hope that nurses know the patients, they know how the ward works, so they should have good ideas. Now, here's one where you might have a signal of, oh, there's something going on. And we really need to look at this because we are seeing some process, some implementation issues happening. So you'll notice on this chart that, we had this big uptick in central line associated bloodstream infections, or fondly reduced to CLABSI. And so you can see that there was kind of an uptick happening, and so it was like, what was going on that was but the uptick was still within the parameters, so that was okay, but still going up, and then it spiked. So what was happening in month 11 of that data period? Were we really short of staff? Was there an issue with the supply manufacturer? Did a new type of kit for managing the central line get implemented that maybe it was a different quality or different ingredients? You can do the root cause analysis to look at what explains that uptick, and then also look at afterwards was what was going on. And also, if this uptick stays up there, then there's really something going on. But this is a signal that can help you get a sense of, oh, I need to pay attention to that as a manager and start looking at what's going on. And there could be multiple factors. It could be related to things that are outside of the nurse's control. And it could be related to practice. Or maybe this was a month where you had a lot of new hires or new physicians working, right? And so maybe that explains what it is, but it helps you keep an eye out for those things and then take actions to improve the safety. Pretty cool, huh? So when we're thinking about this in relation to quality improvement QI data, it makes the data friendly to your ward nurses. So they can look at these charts and you can post them on your unit and they can see the quality indicators and they can be like, yeah, we're doing okay. But it gives you a way to talk to people that's data driven, that tells you, okay, look, we see an uptick, that's out of our normal. Let's talk about what was going on then. And it also helps you remove that punitive aspect of the data. Nurses feel bad enough when something goes wrong. They don't need an added thing to happen to go with them. So really it helps you shift that unit culture to one that is proactive and safety oriented instead of being punitive when we see upticks in trends like this or infections or quality issues. It also really helps the ward nurses to understand what's normal for the patients that they take care of. So if it's normal for oncology patients, if it's normal for kidney patients, whatever it happens to be, then that's what they'll understand. And if you have a nurse who, say, has been pulled from another unit and they are trying to understand your patient population, they can understand what's normal for your population based on the safety and quality indicators. And once you start doing this with nurses, they actually like it. It's weird. I mean, nurses actually liking the data. I mean, we try and create that culture, but we know there's a lot going on. And it feels like one more thing when you have a very busy patient assignment. But if they can see it's working, it really helps them engage with quality improvement. Any questions on this one? Do you have ideas? How might you use this on your ward? And someone can interpret if you want to ask in Thai.
This mean
Quality improvement. Yes.
Does anyone want to share?
Or are we being shy?
Hello. À, Khemika Pongsi. Khemika Pongsi. In quality improvement in my hospital, I use CQI. Yeah, I use CQI. I'm working in our patient department, and we have conflict with our OR.
Mhm.
OR word about set for operation. So we are discussed and consists about flow about to send operation, and something is some topic is make operation delay.
Yes.
Yeah, delay and time to set in time.
Yeah. So you
So
can
yeah,
use to measure delay
yeah,
and understand what's normal
yeah,
or when there were lots of delays, what was going on.
yeah. So the new platform. We are when we set operation and the day that we pass to when our patient register, they pass into OR room, not stay in outpatient department.
Yes, you can use it for that.
Okay.
And if you have someone who can track the data,
Yeah.
then it can be plugged in.
Yeah,
And you can
like this.
evaluate. Then you can say, oh no, that's your fault.
Yeah, it's my
But-
fault.
Well, not your fault, but you can determine where is the delay coming from. Get a better sense because, the people sending the patient are going to say, not our fault. The people receiving the patient are going to say, not our fault. And so then you can figure out, well, where's the issue in the system? It's really good for figuring out system blocks.
for sharing.
Good afternoon. My name is Janjira. First, when I see the picture, I think this is a control chart in my country.
Mm-hmm.
It is similar.
Yes.
Ah.
Yes. Same thing.
Okay.
Some places use it, some places do not. Yeah. So control charts.
Control charts. Normally, we use a control charts to report about infection control rate in my hospital, and after nowadays we use a control chart in is a quality tool for many to check report some many report.
Yes.
And in my opinions, control charts is a report something is a warning.
Yes.
Yeah, for medical staff, and is they delay or not?
Yes.
Because of we input some data, and after they report. So
Yes.
sometimes I think it's delay for hour.
Yes. And when you have to rely on data being entered, there will be a delay. But if you transition to electronic health record, then you can almost get it in real time. But the electronic health record, depending on how it's designed, may make that painful to get the data. Depending. But yes, it's that there's always a little bit of a delay, but it can still, I think it's still useful for understanding performance over time.
So it's better if we can mix and match. Maybe use AI or some electronic to make it update, delay.
The challenge with AI is it needs to do that type of work. It needs very, very careful training. And you need to be working with data that doesn't link to patients, because depending on your patient health information privacy laws, if you use like an open AI or ChatGPT or anything like that, you're putting patient data into a public space. So you really want to make sure that if you're using AI, one, you work with a data scientist to help you train the model, but two, that you are using it in a closed system so that you are not feeding the public one patient information. Yeah. And it may make it more difficult and more steps. It's not, we're still learning how do we use AI and how do we make our work easier. But a lot of cases, it can give us a lot more work. It's great for generating competency checklists. I can tell you that much. Oh, the screen up there is, oh. Yes, nice to meet you.
I'm from Department of Nursing Administration, the same
Yes.
department as Dr. Apurity. So very interesting for your presentation. And we also teach about the control chart in quality management course. One thing that I found in your presentation is about how to determine the variation. So you use you present as you use about three sigma to see the upper limit and lower limit. So can we determine using 2 or 1 sigma for check the variation?
I'm going to have to ask my husband, the mathematician and expert in this, about what are the right formulas. But he used to teach this in the United Kingdom, so he has templates, and I will ask him to share a template. Yeah, it will have the formulas in there already. Yeah.
Thank you. So we wonder that why the variation is very different. Sometimes they use two standard deviation or three. So that I don't know the reason that all the appropriate SD or Sigma that we should use?
And I think that will depend on the situation, and it may be different for each type of patient or problem. And the root of like a major deviation or a statistical outlier, you may have to do more qualitative work to find out what happened or what was going on. Other questions? All right. Hot topic always, shift work and scheduling. Everywhere in the world. We share this as nurses across all countries. So there is a lot of research being done on this topic right now. So there is some interesting research trends around scheduling, which is looking at can we look at our patient population and the different types that they're coming in, and can we do scheduling that way? And there are apparently some AI tools out there that can help us forecast in real time. And maybe avoid surprise understaffing. So for example, if we know that on Friday the surgeons all want to discharge their patients to get people home on the weekend and reduce weekend staffing, can we staff more people on Friday and look at other days of the week where maybe we don't have as much staff? Maybe on Monday, or if the census is low, we don't have as many people on day shift, but when people are being admitted later in the day, we have more people on evening shift. So it's really taking a look at what are the trends specific to your unit in terms of admission patterns, treatments, procedures, how those things work, and can we use more of an acuity-based staffing approach? Another thing that some hospitals are doing, I've heard this is happening in many European countries, of course, the US and Canada and Australia, but they're building what they call an internal float pool. So the idea is that you have nurses who their job is they come in and, okay, what floor are they going to? And so maybe they're going to an orthopedic floor one day, maybe they're going to a med surg floor one day. But the idea is that this is a pool of people who are willing to go elsewhere, but it's also people could decide, oh, maybe I want to pick up an extra shift. Now, this is easier to do if you have 12-hour shifts, but if you have 8-hour shifts, it can also be a case of maybe pick up 4 extra hours. Maybe they're saving for vacation or a house or something like that. They want to work a little extra. But the idea is as long as the internal staff have the choice, then they can staff and be assigned that way. For an internal float pool, it's usually comprised of experienced nurses. And these are nurses who are very happy to change every day, or they're happy to spend 1 month on one unit, 1 month on another unit, whatever it happens to be. It's not great for new graduates because you really have to understand the system and patients and the nursing role to really feel successful and comfortable in an internal float pool. But if you have someone who's very experienced and maybe they want to try something new, it can be a really great way to give them a chance to try new things. And maybe they find, hey, you know what? I really like cardiology nursing. And so if they like going to cardiology, maybe then they can go work on that floor. So it gives people a way to try new things if they started off in a place that maybe wasn't their first choice. There's also the importance of the digital disconnect. There are some staffing and scheduling applications that are out there, and they seem like a great idea, but then if they keep getting notifications when they go home, if it's on their personal phone, there's no separation from work and personal life, and that can be a source of burnout. So you have to be very careful on that one. Another trend is administrative offloading, which is automating the schedule or giving nurses the ability to do their own schedules. I know this is crazy idea, but if the nurses on the ward decide what these staffing norms and scheduling norms are going to be, then they make the commitment that they will have all of the shifts covered. They can choose when they work, and you as a manager, you don't have to do the schedule anymore. And the research shows that this could free up as much as 20 hours a week. Can you imagine? So that gives you actually time to talk to your staff. I know, weird that talking to staff, finding out what they want. But so this is an interesting concept, and it just would take a brave nurse manager to test it out. But there's also the issues of the 12-hour shift versus the 8-hour shift. I understand this is a hot topic in Thailand right now. Yeah. So there is at least a decade's worth of research out there on how 12-hour shifts impact nurses and patients. It's usually not good. So the problem with the 12-hour shift, yes, it's great. You only need to work 3 days a week. You know, nurses love that, but you know, nurses are a little bit of workaholics. So you know what they do? They go pick up another job because they're like, well, I'm not making enough money at my current job and I want to be able to buy a house or pay for my kids' school or whatever it happens to be. And so then you have increased rates of absenteeism, which becomes a problem. So you try and solve one problem and then you get another. And then in terms of in terms of impact on patients, we do see a negative impact on patient outcomes, which is the longer the nurse has been working, the more tired he or she is going to be. And when you're more tired, you're more likely to make a mistake. And then if you add on for that 12-hour shift, what if you live in a city like Bangkok? And I got to know the traffic in Bangkok last week. Say you have a 2-hour commute. So you have a 2-hour commute, a 12-hour shift, and then a 2-hour commute home. Your day is now 16 hours. And then it's going to take you an hour to settle down when you get home. And then you're going to go to sleep. And then you're only getting 6 hours of sleep because you got to wake up and go back and do that commute all over again. So that presents a challenge. I mean, you can burn out very quickly with a long commute. So that's an interesting one, which is, well, if you're going to have 12-hour shifts and people are going to do it back to back, do you provide them with a place to sleep? Which is great if you're single, but if you have kids, not so great. 8-hour shifts. I have worked 8-hour shifts. I have worked 12-hour shifts. When I turned 30, I stopped working 12-hour shift because my knees said no. And 8-hour shifts, though, it's like, yeah, it's short, it flies by, better cognitive performance, less fatigue, but working basically when you have to work that weekend, you feel like you've been working for 2 weeks straight. Big dissatisfier for nurses. And it's also sometimes the patients feel like, wait, I have 3 nurses a day, and they feel that's confusing. But if the other thing that we've seen is your handoffs. Also, you have to have a good handoff protocol because they've seen increases in medication errors with when your handoff protocols aren't strictly standardized. So, you know, there's a lot of infrastructure that have to be in place to make that happen. And so the question is, well, if you can work 3 12-hour shifts and that counts for 36 hours a week, and that's your full-time work week is 36 hours, what are other models that we could have that haven't been tested? So sometimes they talk about 10 hours. Well, 10 hours doesn't really work well with 24-hour care, right? That means night shift is only 4 hours. And who wants to come in and work for 4 hours, right? That's not quite long enough. And, but it does give you 4 days a week. So one thing we talk amongst my colleagues around, a potential shift model, which would be 9-9-6. So 9-hour daytime, 9-hour nighttime or evening time, and 6-hour night shift. So 6-hour night shift, you have young kids. Hey, that's a great option, right? You put the kids to bed, you go into work, and then by the time you can get home and the kids are awake and you still get to sleep. Because we know so many, especially parents of young children, who don't end up sleeping if they work 12-hour shifts, right? But the 9-hour shift is also, it means you only need to work 4 days a week. You can get 3 days off, but it might reduce the risk that you're taking on yet another job. But it does give you the room to pick up an extra shift if you want a little extra money, because we know nurses love that extra shift money, right? Yeah. Here too. Yeah. So these are all choices, right? But I think the key thing is ask the nurses what they want. Figure out what is going to be the normal thing for our unit and what will make it work, and see if you can get the buy-in. It seems like a simple idea, but it's really radical because, healthcare is very hierarchical. It's always been about somebody telling somebody else what they have to do. And especially for women, that has meant limited choices. And so the new generation, they want more choices. They want more flexibility. So test out some models, see what they might be. But if they create it, then they own it. They can't complain about it as much. So it's an interesting possibility. These are all ideas. They could work, they could not work. Another piece around shift work, though, is when you have people working long-term night shift, and you have that nurse, right? Only wants to work night shift, right? They must be part vampire. They don't actually like sunlight, Yeah. Yeah, love the night shift. And okay, maybe that's the way their brain works, that, and you're kind of like, well, but they want to work night shift. Like, why argue? Because nobody else wants to work night shift. So, but there's a cost, right? So, there is several studies that have come out recently that show that if you work night shift for a long time, you have an older brain because you don't sleep as well. So if you're really helping nurses with their well-being, they need to have a really good sleep protocol for when they go home, where it's really black and protects them from the physiological effects of working night shift. And also working night shifts, you're more likely to get metabolic syndrome and high blood pressure. And apparently there's an aspect with scheduling around if you're going from like night to day. It's apparently easier for people to go from day to night. So they need to have time off for a long enough period to switch between shifts, which if you're doing 8-hour shifts and you're doing 2 weeks days, 2 weeks nights, that's not such a great thing for people's physiology. So as we learn about the physical impacts of night shift, we have to start thinking, well, how do we reduce that risk? Is the solution making night shift shorter? Is it trying these new staffing models? Hard to say. And, and we know we can do the workforce projections with these shift models. They're they're simple enough formulas to figure out, well, would that still work even if we're operating in a nursing shortage? But if people are showing up for work more and they're not leaving as much, that might fix it because the scheduling is better. Ooh, and the text on this turned out very small. My apologies for that, but yes. Circadian. So circadian tax. So your circadian rhythm. How many of you are morning people? You can get up at 5 a.m. You're happy. You're awake. Raise your hand. Who are the morning people? Yeah. Who's a night person who loves to stay up late? That's me. Can stay up late. I mean, My mother, when I was a child, getting me out of bed to go to school didn't matter. I was never a morning person. That is how my circadian rhythm works. I do better later in the afternoon. Like my writing time, best time is the afternoon. I can work in the evening. In the morning, I can only pretty much answer emails. That's how my brain works. I had a doctoral student. She'd get up at 5 in the morning, spend 3 hours writing, happy as a clam, but she would go to bed at 9 o'clock. So, that's your circadian rhythm. So if you're not working to your optimal circadian rhythm, your body's being taxed by your work schedule. And the tax has health consequences. So to your brain, to your heart, to your endocrine system. Yeah.
That means if we work on the time that not fit with our circadian,
Yeah.
so that means it gonna may create some impact to our body.
Yes.
Okay.
It can, and it's one of the, which is for shift work, we need to cover. So the idea is that if you have to work a shift that doesn't really work with you, then, maybe the idea is figure out what's your best shift. My best shift was evening shift. Loved working 3 to 11. It was great. Most people were like, but you don't get anything done. I'm like, no, it's great. I wake up and I've slept and, I get stuff done. I attend to life and then I go to work. So yeah, but we can't really schedule based on everyone's circadian rhythm, but we can help people if they're working shifts to, not be taxed as much based on when they're working. So really a lot of emphasis now on helping nurses who work shifts to do really good sleep protocols and cortisol management protocols. Okay. So scheduling, the idea is that if they're scheduling, you should do a forward rotation. So if you start off your working day shift, then ideally the next shift you're working should be in a 2-week period, after 2 weeks or however you do it. It shouldn't be like day, night, each variation each day. It should be, working in blocks and then moving that forward and not going backward. It's really hard when you're going like night shift and then to evening shift and then to day shift or, depending on how you do your scheduling. The other thing is that a quick return to work is like you haven't had enough time to rest between your shifts. This is a risk with 12-hour shifts, especially if people have long commutes. So if you do 12-hour shifts, then the idea is, well, maybe you work Monday, but you have off on Tuesday, and then you work on Wednesday. Now, the trouble is nurses don't want to do that. They want to boom, 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 Monday, Tuesday, Wednesday, Thursday, Friday, get their shifts out of the way. But that can be very, very hard on the body. That's where we see the cognitive issues, and that's where we see an increased risk of the nurse making mistakes the more closer in she is to that 3-day, 12-hour shift period.
Question.
Yes.
Can you explain more how scheduling in U.S. hospital look like? Because they mix between 8 hour and 12 hour or just 12 hours.
We're seeing for a long time, everybody was doing 12s. But because for a long time, everybody did 8s, nurses didn't like that. And 12-hour shifts are done because there's a shortage and you need fewer people to schedule. So, but we're finding that now we're seeing different alternatives that are coming up. What we're seeing is more control over scheduling for the nurses is helping to mitigate some of the effects of the 12-hour working day. We're also seeing places try different staffing models or different scheduling models, like bringing people in at 11 o'clock if you have a lot of post-ops that come in the afternoon. If you bring in a nurse at 11 o'clock to take on their post-ops, that can be another way to have a bridging shift. But really looking and exploring. Some places are being very innovative. Some places, they've been doing it the same way for the last 50 years, and they're not going to change. I'm sure you have places like that too. But yeah, we're seeing more of a mix because people want an alternative. But we're trying to find what's the balance between, having someone work full time and having that extra day off is always helpful in terms of reducing absenteeism and burnout, that kind of thing. But balancing it with the 12 hours. In Europe, in particular, many countries have just made all work weeks 32 hours. 32. And that is considered, some countries it's considered part-time, some countries that's considered full-time. My argument is that 32 hours a week for a nurse, that's full-time because of the emotional aspects, emotional and psychological aspects of the work that we do. We're having a very intense 32 hours. It's not like now when I sit in front of the computer all day, and that's not stressful, So a couple of things that we're also seeing around schedules and shift work. There's a really interesting trend around allowing nurses to do power naps during night shift so that they can nap for 20 to 30 minutes. And even if they're not really falling asleep, just the quiet reduction in sensory stimulation for 20 to 30 minutes has shown to significantly improve alertness and reduce errors. And some hospitals are now creating nap pods or formal napping protocols. Unionized hospitals in particular have latched onto this as a way of guaranteeing nurses a break. Another interesting thing that they're doing is looking at the lighting on the ward and looking at exposure to blue light. So you know how you shouldn't use your phone right before you go to sleep because of the blue light? So they're looking at, can they reduce blue light exposure to nurses at the end of their night shifts or have like blue light blocking glasses because it helps reset their circadian clock. And it helps them sleep and go back and have more normal sleep because the blue light, which is the fluorescent lights that you also get, interferes with your sleeping. And the more exposure you have during a shift, the harder it is to sleep afterwards. It's an interesting environmental aspect. And like I was talking about before, the rise of self-scheduling and flexibility. So the idea, and again, two different approaches here. So there's acuity-based scheduling, so moving away from this idea of a fixed ratio, because you could have one nurse for 5 patients, but all of those patients could be really, really sick. And that's not going to, your ratio has just gone out the window in terms of what it was intended to fix. And the other thing around self-scheduling apps. So, the idea that nurses are empowered to pick their own schedule and, in a way that can coordinate with their partner and their schedule. And so when they feel like they have more control over their work schedule, they have more psychological resilience and their work-related stress also reduces. And it really moves away from hierarchy-driven scheduling, so scheduling driven by seniority or whatever. But for experienced nurses, one of the things that really keeps them working is when they have fixed schedules, when they know I'm going to work Monday, Tuesday, Friday this week, and then the following week I'm going to work Monday, Wednesday, Thursday. Or they throw in their weekend shift or whatever. But when older nurses have fixed schedules where they know that their schedule is exactly the same for the entire month, every month, they're more likely to stay working and take care of patients. And that's valuable for the new nurses to have more experienced people to draw from. So this is sort of the summary around, the idea around scheduling and staffing, which is, how do you manage the rotation in the scheduling? And there's software that can help avoid these things. It's literally built in there. There's recovery, are they able to get 11 hours off to prevent that quick return fatigue? And, the napping, power naps, can that be built in? Giving nurses more autonomy around self-scheduling, and then making sure that they're not working more than 12 hours a day, because your risk for error is going to double after the 12th hour, and it doubles every hour after that. Anybody get some ideas?
Any ideas? So now Thailand, we 8 hour for
Mhm.
working, and will become 12 hour. But we still discuss about this issue.
Mm-hmm.
Because but I believe some hospital they implement 12 hour already
Mhm.
for some ward or some unit.
Yeah.
Yeah, but yeah, and I heard that some unit they back to love 8 hour
Mhm.
after they try 12 hours.
Yeah.
Yeah. So
And it's good to let people try it, because it may sound like a great idea. Oh, 3 days a week of work, but 12 hours is a long time, and you feel it in your body. Yes. Yeah. And especially when you have lots of patients, 12 hours is a long time.
The unit they initiate to apply is that the special unit. So that means they take care patient that not complicated
Mhm.
symptom. Yeah.
Yeah.
So I think this kind of schedule is may fit with some
Mhm.
unit, but for some may still should
Yeah.
think about that.
Yeah. And if there's the ability to test the model and measure and gather data and evidence, then that's a good thing, if you're able to do that. I mean, I know it's hard, believe me. But, if you've got a ward that is willing to do that, why not? Try it for 3 months, see how people like it. They're like, no, please, 8-hour shifts. But also look at you all get to do lots of financial modeling. Like, look at the modeling. You can do the modeling first, which is, what would everybody working 32 hours a week look like? How many staff would you need? Would you get more staff because people are like, oh, I'll work 32 hours, have more full-time, part-time. Be interesting. But again, this is a case of ask the nurses, see what they might think is a good idea. I know that's the big idea, really. Ask the nurses. Revolutionary. All right. Our last topic is nurses' mental health and well-being. Again, especially after the COVID-19 pandemic, a very hot topic everywhere. So there's a lot of assumptions that happen around nurses' well-being, and the one that annoys me most is that nurses don't know how to take care of their own well-being, or that if you give them a pizza while they're working, that this will help their well-being. It's like, well, it will save me from buying lunch, but I think we have to move away from the assumption that nurses don't know how to take care of themselves and their well-being. But we do need to be looking at, well, how do we identify actually when someone's having a really rough time and it goes beyond just one bad day, that it's becoming cumulative over time and it's hurting their mental health. But there's a lot of issue around measurement with mental health and nurses because there's a stigma. Lots of places have stigma around mental health. Health professionals don't like to say that they're having problems because, oh, but there's someone else who has it so much worse. And, you know, they don't validate their own feelings and experiences because someone else always has it worse. They also know what depression and anxiety are, right? And they don't want to label themselves as being depressed or being anxious, right? And so that becomes a problem when you're thinking about measuring. Now, in the study that Dr. Apiridi and I did, we were looking at nurses' mental health symptoms. And what was interesting is nurses wouldn't say that they were anxious or depressed very much, but boy, they would say they had all of the symptoms, almost at rates twice as much as the naming the diagnosis. So that was a very interesting measurement issue. But the other thing we don't know is we don't have good data specific to nursing or other health professions about their mental health. And so if we don't have good data, we don't know a good starting point. So I'm going to show you some interesting slides here. So anxiety at work by country. So this is data from my consortium's COVID and nursing study. And we have data points from over 14,000 nurses from 103 countries. And so this is a funnel plot analysis, and it shows which countries, the countries in red, have more anxiety at work at a statistically significant level compared to the nurses below the line in the green, that they have less anxiety at work compared to the average. And everybody in the middle there is sort of, you know, performing within a normal expectation in terms of who is reporting, yes, I'm anxious at work. And so Thailand, interestingly, was reporting lower comparatively to other countries. What I find really interesting about this data, though, is there's no cultural pattern. You know, if you look at the countries that are there, it's like, well, these are all different parts of the world. They're different languages, different cultures, different aspects of mental health. So that's that's an interesting finding in terms of how do we understand what it means for a nurse to have a mental health challenge at work. But we also ask them, well, you know, are you more anxious at home or are you more anxious at work? Because we know that women during the pandemic, because of added home responsibilities, often had a lot of stress at home as well as at work. And so, again, we see absolutely no cultural pattern here, but there's definitely a strong correlation between anxiety at work and at home. And Thailand is one of those dots. I'm not sure which one. My husband does my statistics, so full confession. So I'll have to ask him to highlight Thailand. But you can see that, you know, in some countries, their home life was more stressful. In other countries, their work life was more stressful. And again, we have high income countries on here and we have low income countries, but there's no trend. And again, feeling depressed at work. So you can see, here's a cultural signal. Poland, no one's depressed in Poland. And my Polish nursing colleagues all laughed. They said, yes, no, none of us are ever depressed, ever. Because there is so much stigma with depression or anything mental health. Because under Soviet rule, mental health and psychiatry was used as a weapon of control of the population. So you could be taken and interred into a psychiatric institution for any reason. And whatever that reason, you were told you were mentally ill. And so there is a huge amount of stigma in a lot of Eastern European countries and former Soviet Union countries because of that. So as you see, no one in Poland is depressed, but there's a huge cultural stigma around that. But they did have symptoms just as equivalent as everyone else. But again, no particular trend around depression at work. Oh, there's Thailand down there. Very low rates reported in Thailand of depression at work. I know, and you're all like, well, but actually, depending on the week. But that's why, naming the diagnosis, it's like, oh, well, are you anxious? Are you depressed? That's why you have to look at the symptoms, right? So when we're looking at, and again, depression at home versus depressed at work. So, the US was depressed at work and also depressed at home and depressed at work. So, I got no explanation for that. Well, I have a few theories, but, there, again, no cultural trends looking there at all, but there's a strong relationship, as you can see by the line, by the correlation line there. But we also asked the nurses about, do you seek help for these symptoms, for both the symptoms or the being anxious or depressed? And again, no cultural consistency. Well, you see, no one in Poland asked for help. See, down the bottom. And when I presented this work in Poland, they all laughed. They're like, yeah, it's an issue. Sort of a little dark humor. But, when you look at who's seeking more help, no cultural pattern. Seeking less help, other than Poland, no cultural pattern that we can understand. So it's a fascinating thing. So I bring this up because measurement is a challenge. And so we may not be able to quantify it with our nursing staff. It really is going to require probably more qualitative assessments on your part. But just the little thing of checking in, how's it going? Or noticing your staff of who seems to be freaking out that day, or like maybe isn't talking as much as they should. Whatever, your staff. So when we're thinking about nurses and mental health and well-being, when we're thinking about measurement, we need to figure out what makes the most sense for our population. And I think it's really important. Ask nurses what they need. Don't assume you know what they need. Maybe all they need to do is talk. And maybe it's just create a place where if a nurse has a bad shift, they can go talk to a social worker, a mental health nurse, a psychologist, whatever. When I was doing new graduate orientation and preceptorship programs, most of the time I found when the new grads finished the program, in that first year, all they needed was somebody they could regularly check in with and talk to. That was what kept them working. Just somebody to process. Is this normal? Does that doctor always yell at people? Understanding those types of things. What's normal in the context. So that management check-in really could be useful. And also just when there's the bad day, I mean, you all know what the bad day looks like on your unit, but just recognizing staff and acknowledging them before they go home, like, we know it was a bad day. Sorry about that. I had one manager that I had to deal with one time who, there was no such thing as a bad day. It didn't matter. If you stayed after because you didn't get your work done because it was a bad day, then she's like, why are you billing me for overtime? It's like, oh, thank you. You're so empathetic to this really bad day we had. So, just thinking about, these are just little things, but they're little things, in terms of soft skills that can have a big impact on staff mental health and well-being. And also, I'd like to do one more plug for getting rid of the toxic nurse. I know you have them. They're everywhere. Every country I go to, everybody laughs when I mention the toxic nurse. They look a little different, but it's the same behaviors. They're just mean to everybody. They drive people away. They always point out everybody else's mistakes. They make everybody miserable. But some managers, they want to keep them because, oh, they have so much experience. Or they're too afraid of losing somebody because then they'd have to fill that. It's like, yes, but maybe you're not filling your vacancies because everybody knows that toxic person is actually working. I have had so many former students leave because of toxic people that their managers wouldn't get rid of. So that's my plug for, do you really need to tolerate that toxic person anymore? Find a way to make them, help them either be not toxic or maybe move on to doing something else. Questions? There's my this is just a small touch of references that were used to build this presentation. There is a lot of literature out there on shifts, 12-hour shifts, scheduling. Well worth looking into. Would make a great thesis, just putting in a little plug. Questions? Yes.
It's about the mental health.
Mhm.
Yeah. I want to know something. In your country, have a screening mental health for before start nurse or before to work to include to exclude the place or have a problem of mental health from work or absolutely have some problem before go to work?
No, we don't have that type of screening because that would be considered discrimination in hiring, because your mental health history should not affect your future employment. Because if you have had help and you know how to manage your mental health issues, then and you can balance your employment, then that shouldn't be a cause for not hiring. But I think if you are a good interview, when you hire someone and they're doing an in-person interview, you can tell when there are potentially problematic issues. But I think the better intent is find the right job for them. Maybe if they're not good with talking with people, hey, they could work in the OR, in the operating theater. You don't have to talk to people there, right? It's really about working with people, I think, to find where would be the best place for them. The idea of practice inclusion, there should be a place for everybody, who's willing to work, who's going to be supportive, who's going to be a good coworker. The toxic people need to go, but yeah.
In my opinion, I think if we know some problem before go to work, we prepare some way for her. But now today in my hospital,
Yeah.
we have some problem. This problem,
Yeah.
and we know when we get she in my policy, and after we just to treat her.
Yeah.
We cannot use her to work,
Right.
but we just treat her.
Yes.
Yes. So I think if we think retrospective thing, we have some policy or some screening to know before is better.
Yeah. And again, this is a measurement thing. So many of the measurement tools for mental health issues were developed 50, 60 years ago, and they haven't really been updated. I have a faculty member who's been looking at this issue very closely, and they were all developed. A lot of these mental health screening tools were developed in Western countries and reflect certain cultural values. So the question is what would make sense for the Thai context? Like, does that measure make sense for the Thai context, or should there be something else? Yeah.
Yeah.
And it might apply because, there are aspects of healthcare that are the same everywhere. The gallbladder is in the same place for 99% of the world's population. And if you're going to treat that, it's pretty standardized. But Yeah, thinking about, does this measure make sense?
Mhm.
Yeah.
Okay, and go back to your hot topic with
Yeah.
12 hour. Yeah.
Yeah.
I'm not sure about the policy change or not change because of today we have one hospital in North country have against. Yeah.
Mm.
And now I think one people in my opinion now, yeah, after I listen today, it's very interesting about the internal fraud pool.
Yes.
Did you say that? Yeah. Because of I never hear it before.
Yeah.
We have some problem when we change, but if we have preparing
Mm-hmm.
about the internal fraud pool, yeah.
Yeah.
So I want to know and please you explain it again. Yeah.
Yes. So the internal float pool, I worked internal float pool after my first year as a nurse. And so basically, they had a pool of people that were either full time or part time, but a lot of people who worked what we call per diem, which is you could work 6 days per month, and that was all you could do. You couldn't work more than that. Otherwise, you had to be classified as full time or part time, and you would get benefits at a certain level when you were full or part time. So we do not have universal health insurance. So most people who work per diem do not have health or retirement benefits, but they may not need them for whatever reason. So the pool of people and the number was based on what we know for how our census goes and the demand for services. They had a pool of people that they could assume, we'll say every floor, every day could potentially have someone who calls out, and we have no one to replace them. So instead of pulling someone from another floor to replace that person, you have the float pool. And the float pool person could be sent to wherever that vacancy is. Or say you have someone going out on maternity leave, and they will be out on maternity. How long is maternity leave here? 3 or 6 months. 3 months. Okay. Sometimes 6, maybe. Yeah. So if say it's 3 months, then that float pool person could be permanently assigned to that unit for 3 months, cover that nurse who's been out, and then go back to the float pool. And for some nurses, this is great. They love going to a different place every day. They love the variety. They love learning about the different specialty practice areas. It was how I discovered that I really liked transplant and how I really didn't like neurology. But I learned how to take care of all these different types of patients. And for some people, it's a great fit. But people who want to do that usually volunteer. And it means that they may leave their floor but that's okay. But if they're part of the pool, so they would come in whatever day they're scheduled, and they would get sent to wherever there was a need. And the need could be prioritized based on, number of surgeries, the number of patients on the floor, number of procedures, how many vacancies there are that day. It's a good solution. Can be a good solution. So you're keeping your employees internally, and you're keeping the staffing levels up. And especially for someone who maybe is very experienced and a little bored, this kind of new challenge could be useful. But it also reduces dissatisfaction for nurses when you get pulled from one unit and you have to go cover another unit. Nurses don't like to do that. They like their home unit most of the time. But the float pool, that's their whole point. They get assigned there. And there's ways to model, like, what size do you need? How many positions? If you could also have per diem positions as well. What else?
I want to share idea. In the other hand, I have a file from Swanpacharak Hospital. It's a tertiary hospital. There are research for this 12 hour compared 8 hour.
Oh, wow.
Yeah, outcome is very good for 12 hour.
Oh, okay.
Yeah,
And again,
and they say work life is real.
yeah. And it's one of these things where, you know, you understand the state of the evidence, but you track the data and always show the link to outcomes,
Mm.
because it's the outcomes that ultimately matter, both the nurse outcomes and the patient outcomes.
Mm.
Yeah. And it can work. Maybe it does work really well. I think, but there's not bad traffic here in Chiang Mai, right?
Yes, Swanpacharak share, please, you try to change for 3 months and you keep a data.
Yeah.
Yeah, you
Yeah.
can see something maybe changed.
Right. Maybe people like it.
Yeah, they like it.
Yeah.
Yeah,
And if they like it, okay.
they get a long day off.
Yeah. I mean, if they like it, great. But if they don't like it, also, what would be the solution?
But it's limited about a nurse is over 50 years old.
Oh,
Oh, yeah,
interesting.
yeah.
So the nurse is over 50,
Yeah, over 50.
likes
She
the
can't-
longer shift.
Yeah, the long shift.
Really?
Maybe it's are flexible for this group.
Ha,
Yeah,
interesting.
interesting. Is for over 50, she can work with a third hour as the same.
Ha, who knew? You should publish that. Seriously. Not what I was expecting to hear, but you never know. This is why, I can talk about the state of the evidence, but you've got to have
Yeah.
the local example. And again, it's what do people want? I think that's the main message is, can you help them, give them what they want? Because if they have what they want, they won't be burnt out. They'll be more likely to stay and the staffing issues will reduce.
But the nurse must accept our money is decreased from at the same.
Yeah. Because you're only paying for 36 hours and not 40. Now, what they do in other countries with 12-hour shifts is they have the nurse work 7 days in a 2-week period, because that technically is 40 hours. But that also means there's 8 hours of overtime. So that actually it still ends up being cheaper somehow. I don't really know, but they make them work the 7 day because that balances out a 40-hour week with that extra 12. So it ends up being 4 hours of overtime in that period.
Professor, I have a wonder about a train graph. The last graph. I'm not sure about the work. Anxiety and depressed who work. Yeah.
This one?
What the work from the data? What occupation? A nurse,
These are
or
all nurses.
nurses
Mm-hmm.
is real.
Yes. 14,000 participants. Yes. 300 something from Thailand. Yeah. Yeah, she got the data. So
I'm sorry. I'm just.
yeah. No, it'd be hard for me to make this up. Yeah. Yeah, we are still collecting data, so we will finish in June. We have, I think, 5 countries that are still collecting data. So then we will be able to do lots more analyses like this.
Okay, one more.
Okay.
Uh, uh, it's great to insight. It's interesting about research about physiology related to a night shift. But I'm working in our patient department. If I want to do a deep research like this, I don't know. The topic of my research is
You
Yeah.
suggest the topic for her.
yeah.
About the physical problem, right?
Yeah,
Yeah,
it's a
night.
problem. No, but I'm working operation department. Please guide me a topic of research.
Oh, for night shift?
No. I'm working at outpatient department. I'm work only a day. Yeah, 8 till 4 o'clock.
Well, I think your topic should be what problems do you observe that you want to solve? So, because that will be the most interesting for you and for your work. So, ideally, you pick a topic for your thesis that will help you in your work. That way, it doesn't feel like as much work.
We are working for tech history, so we are work with a computer all day. The outcome we are fat,
Oh, well,
and
yeah,
we have NCT.
yes.
Yeah, NCT
Yeah.
problem.
When I stopped working on the floors, I think I gained 10 pounds, 5 kilos. Yeah. So there's good occupational health research around how to improve activity for workers who sit in front of the computer all
Yeah,
day.
yeah.
And so your study could maybe be, do people work with a timer? And the intervention is that the timer goes off and people have to stand up and walk around and move. And there's good research that shows that if you can even do 5 minutes of activity that's not sitting, it improves it reduces your metabolic syndrome risk.
Professor, but it have a many factor for this is a difficult to
Right.
is
So when you have a difficult problem, then you test different ways to solve it. And maybe you don't solve it on the first try, but that's okay because we also need to know what doesn't work. We don't have enough. Everybody wants their research to show that something made a difference. But I actually like it when research shows that, nope, that didn't work because now we know, oh, don't do that. It rules out one more thing, gets us closer to figuring out what will work.
Thank you, Professor.
Okay. You have any questions? Yeah, PhD student, please.
I'm a PhD student. I want to ask a question. First is you said you focus on nurses' mental health. So there are 2 outcomes. One is for themselves, another is for the patients. So I want to know how you measure the outcomes related to the patients.
Well, we haven't. So with our COVID study, because we were getting, national level data, it would be very difficult to link that data to patient outcomes. But at the same time, when we finish data collection, I'm going to task my husband, who's a statistical wizard. He's one of those. And he may be able to figure out if we can link. But it may be that the nurse explains part of the patient outcome, but not all of it. So that's always something, because a patient outcome is in part their contact with the health workers, the place where they receive care, and also their own personal health status and how they manage themselves. So when we think about the patient outcome and the impact of the nurse, we have to consider all of those factors.
You measure the nurses' mental health, just their subjective well-being or others?
Subjective well-being, because the issue we ran into was we were doing this study collecting data in 27 languages, and we did not have instruments that were valid that were translated into all of those languages. So because of that, it presented a real measurement challenge. And so, and we also, as a team, our experts thought, well, we know nurses may not answer questions involving a diagnosis, so how can we get a sense of their mental health or their well-being? How we also ask them about self-care and their self-care practices, and are they doing better? Are they doing worse? You know, most actually did maintain the same or did better, and that was fine. So yeah, entirely self-report. But the idea is that we don't have standardized measures specific to nurses, so we will be producing them from this study, and it will be available in every single language. So for people online, the question is how do we do scheduling and balance people's levels of experience? So this is a global challenge because we don't know how long, what's the average length of time people work at the indirect care roles. And so knowing how many people might have experience that could be good resources, and I would like to say experienced, nice people, not the toxic experienced person that is going to scare the new people. But how do we balance the scheduling? And this is where I think it becomes important. Like you can do mathematical modeling, I'm sure, to indicate how many people should be there for optimal outcomes. But if you don't have that type of math skill, then I think the best way to do it is to talk to the staff and say, what will our staffing norms be? Do we want to say we need to have an experienced person on every shift so that the new people always have a good resource? Now, what's interesting is I haven't seen research yet, but I have heard cases where the ward is entirely new people and all who have, say, 2 years or less experience, but it can actually work really well because they all know they're new, so they have really good teamwork because they're trying to just get through together. And it can create a really positive culture on the unit that's good with teamwork. So, I totally appreciate and agree that an experienced person would be great, but what other ways, if you don't have enough experienced people, what other ways could you use them? Like, so could an experienced person rotate to floors and check in with people and say, what's going on? How are your patients? Do you have any challenges? Need any help? Especially for a complex case and spotting things in advance, because the advantage of the experienced nurse is their ability to understand when the patient and identify early when a patient is having a critical change in condition. Unfortunately, it's not something we can teach our students. We can give them an idea of what it looks like, but until they see it, a lot of times they're not going to pick up on it as easily. So these are the balance of the risks. But I think asking the nurses on the floor, what do you want? What shall our norms be for this? How do we want to organize it? That can be the way to go. Yeah. Again, these are ideas. You guys create the evidence. Prove me wrong. What else? Well, if nothing else, online people, any questions?
My name is Konkita Konahedeza. On behalf of the Nursing Administration Study, I would like to say thank you. Thank you very much for sharing your knowledge and experience. Research today, your presentation was many valuable insight into the current trend in nursing setting, and such as the work shift, never learn each day and never learn today, and it's both informative and inspiration for all of us. We truly appreciate your time and your contribution to this section. And thank you again for the wonderful presentation. Thank you.